So this is a great next talk, because I think it just really just follows really well after what Chris has taught you guys. My disclosure's already.
Don't do that. I turned this one on.
And should be controlling. Here we go. So the background was completely described by Christian Art in our last talk. He did an outstanding job of kind of highlighting the differences in at least the classification system of how we recognize glenoid wear. But if you think about posterior glenoid erosion, it's really the B's and maybe the C's that you're really worried about. And there's a lot of ways you can manage these when you're dealing with an arthroplasty, and Chris highlighted all of them. You do a hemiarthroplasty, where you can either accept version or do a ream and run. You can do a total shoulder arthroplasty, either accept it as version, correct the version partially, or use a augmented glenoid to normalize the glenoid version, or you could do a reverse. And I think all those have controversies. But these are the problem patients, right? Here's a 38-year-old physician, pain. He's actually a radiologist, and recognize that this is not your normal posterior labral tear, right? There is posterior degeneration. There's actually cartilage that you're starting to see eroded in the posterior portion of the glenoid. And so what do you do about this patient? Is this a solvable problem? Is this a B0? I like that Chris introduced that concept of a B0, because I think this actually is a B0, that this is destiny, that this will progress from B0, 1, 2, and maybe down to a 3. And I showed this case before in my last talk, but really I keep emphasizing this is what we're really trying to avoid, because it's the B2 glenoids that often are the bad players. And you can have this B2 glenoid. I did a partial correction, looks good at a year, but gosh, at 3 years when it's coming out the back, and there's a problem. And I've probably seen this four or five times in my practice. It's very rare, but I think clinically this is happening more than we really appreciate. I think patients are often going out the back functionally, like they have been for many years as they've eroded their glenoids, because that's the pattern of their muscle memory. So take this case, a 37-year-old male, 10 years after a posterior dislocation. So he had an instability event. He has pain with forward elevation of 90 degrees. He needs something done. He's failed non-surgical treatment. And if you look at his MRI, you can start to see that he's got not just posterior labral pathology, but he's lost a portion of the posterior cartilage surface. So what is going on here? Do you think that doing a labral repair like was done here, where we take that cartilage devoid area and advance the capsulolabral junction into that area to cover it, and hope that we are actually making a change? And so what happens? Well, 3 years later, he comes in, and now he's got a bad problem. He's not hurting tremendously yet, but at 37 years old with a posterior subluxation to that degree, it's a problem. And I don't know that we've changed anything with the natural history. So this 31-year-old male comes to me, different patient, has already progressed to this point, but is miserable and wants something done. I don't know the right answer. So this is a patient I sent out to Seattle to have a hemiarthroplasty done with a ream and run technique. And he's doing quite well, and I'm following him post-operatively, but this is the challenge. These are the hard players. I'm not quite sure what the right answer is for this patient. When it comes to total shoulder arthroplasty, we've been told that glenoid bone loss and retroversion can increase the complexity of managing the glenoid in primary arthroplasty, and it's been associated with early loosening, and that failure to restore glenoid version to normal values may lead to premature loosening. And there's certainly plenty of mechanical data that would suggest that as well. But how might you manage it? Well, eccentric reaming is a technique that I use quite often. It eliminates the biconcavity and corrects, or partially corrects, the glenoid version, with the primary goal of creating a concentric surface, basically trying to create a mechanical environment for the glenoid so there's not going to be toggle and there's not going to be added stress. And you could do that by making sure you line-to-line match the glenoid to the concentric surface of the prepared glenoid. And then a secondary goal is restoring version. So you can do that in this 70-year-old male who's got clearly evidence of a B2 glenoid with a slight degree of medialization and certainly subluxation at 77%. In this technique of partially correcting it, to not bringing it to 0 degree, to neutral certainly, and maybe not even to 10 degrees, but a partial correction, translating the component posteriorly where the muscle memory wants to bring the joint, and doing a standard total shoulder arthroplasty. Here you see the post-operative x-rays, and it's certainly in early follow-up, we're seeing maintain alignment of the glenohumeral articulation without subluxation. And this technique is not just something that I've been using, but it's been a technique that's been described by our group, by the Wash U group, by the Matson group, and the Frankel group, all showing early results that show consistent improvement in pain and function without having any catastrophic failures like that patient who dislocated out the back. Now, you can use an augmented glenoid, and Tom Wright gave a great talk on utilizing augments in order to manage these sort of B-type glenoids. And the goal of this technique is to restore glenoid to a more normal version by jacking up the back portion of the joint by using a thicker poly in the back than the front, either in a full wedge, half wedge, or even a step cut or variations of that. And while there is data, mechanical data, that shows that it makes sense, there's certainly the early track record wasn't so good, but the modern technologies have really improved the allow for it to be used with success. And there's clinical data, but it's all short-term clinical data just because it hasn't been around so long. And I think Tom Wright presented some of that data. Now, my obvious relevant disclosure here is I've never used an augment, and I think my patients are doing quite well. So my preferred technique is highlighted here. Here's a 75-year-old tennis player, 170 degrees of elevation. He's got a posterior glenoid subluxation. The MRI makes it look a little bit worse. Pre-op planning certainly makes it look worse because of 20 degrees of retroversion and 78% subluxation. My plan, as I described in that other technique, the other case that I just showed a minute ago, anterior preferential wear. That means I'm partially correcting the glenoid. I actually take screenshots of the virtual software so I can make sure that as I'm reaming, I am replicating the reamed pattern that I would expect from the virtual plan. And then when I put my component in, I do translate it a little bit more posteriorly because that's where the muscle memory of the joint is going to want to bring that glenohumeral joint. So post-operative, this is a post-op X-ray, and you can see that if you looked at the humerus, this is a technique that I used, and I use this technique when there's still a little bit of posterior subluxation. I've anteriorly translated the humeral head. So if you just look at the glenohumeral articulation, it's pretty much in line. If you look at the axis of the humerus, you'd be going out the back. I'm allowing the muscle memory of the glenohumeral joint to sort of trick itself and allow anterior translation to humeral head during these techniques. So some of the techniques that I use in these B2 glenoids are, I translate the glenoid posteriorly. I partially correct the glenoid version. I anterior translate the humeral head like you see there, and occasionally I'll use a posterior capsular plication. And then you have these extreme cases like this 56-year-old patient, where this is past the problems of B2 and into the problems of B3. Great range of motion, bilateral shoulders look the same, and she presents with a picture of what she looked like a week before her operation. And so this is a challenge because I don't want to do a reverse shoulder replacement on this patient. So I'm going to go, and this is of course our other shoulder, but I'm going to go to extreme efforts to try to make sure I can do an anatomic shoulder on her. So when you do this 2D CT scan, you start to have an oh my moment and say, how am I possibly going to get a component in that glenoid? And that's where virtual planning is critical. And I plan this to have zero correction. I basically placed her where she laid. And much like the technique that I showed in the last talk, I utilize the bicortical nature of the bicortical fixation of the peripheral anchor pegs to gain fixation, even though I knew that I was penetrating the vault. So here you see post-operatively after I did photo shoulder, the same technique on her other shoulder. 3 months later, she's showing me her volleyball pictures where she's back on the court. You can see real carefully, she's covering up her incisions to make sure that she doesn't get them sunburned. But these are the challenging cases. No question, I think destiny is defined itself when you start to see a B0 glenoid, meaning posterior labral instability with early arthritic changes on the glenoid. The jury's out. It's going to be an arthritic process, and you are only temporizing this with your treatment. It's a matter of time before it ends like this. Thank you.